Thank you, Ellie. It's a pleasure for me to speak on behalf of the iPrEx study team about the safety of pre-exposure prophylaxis in hepatitis B infection. This work really was done by Mark Solomon, who regrets that he could not attend this meeting because of family commitments, and he's very proud to have been awarded the IASA-NRS Lang van Tongeren Prize this year for Track C. Hepatitis B is endemic throughout the world, and prevalence of chronic hepatitis B infection is particularly high in sub-Saharan Africa, where HIV is also endemic. In terms of background, oral FTC-TDF or TDF prevent HIV acquisition when used as PrEP and are active against hepatitis B virus. Withdrawal of anti-HBV medications or the emergence of drug resistance may allow HBV to rebound, and some of these viral rebounds may cause acute on-chronic hepatic injury or hepatitis flare. The risk of hepatitis flare is known to be lower with lower pretreatment clinical stage, and that is in the setting of HBV monotherapy treatment or HIV and HBV co-infection treatment. HBV resistance to TDF has not been documented yet in any setting, and there were no HBV flares after withdrawing TDF PrEP among 23 women in the West African PrEP study who had hepatitis B surface antigen and normal AST and ALT at enrollment. Hepatitis B surface antigen positive people were excluded from most all other PrEP trials, except the iPrEx study, which did include people with surface antigenemia. Just to remind you, the iPrEx randomized clinical trial was conducted at 11 sites in Asia, Africa, Latin America, and the United States. A total of 4,459 were screened, and 2,499 were enrolled and randomized 1-to-1 to emtricitabine tenofovir versus placebo. The methods relative to liver health were as follows. We included men who have sex with men and transgender women reporting HIV risk factors. At enrollment, the AST and ALT had to be lower than 2 times the upper limit of normal. The total bilirubin had to be normal or near normal, and that was defined differently in different versions of the protocol. We tried to exclude acute hepatitis B infection using the anti-hepatitis B core IgM test. Hepatitis B serologies were done at screening, including anti-surface, anti-core, and surface antigen. If the surface antigen was positive, or if there was an isolated positive anti-core antibody, we did hepatitis B DNA, but that was done after the study was completed to avoid unblinding. We also measured E antigen and anti-E antibodies. Hepatitis B virus susceptible people were offered hepatitis B vaccine, and surface antigen participants had extended follow-up at 4, 8, and 12 weeks after stopping PrEP. So these are the results of screening serologies for the iPrEx study. A total of 4,459 were screened. You can see here that approximately 2/3 were still hepatitis B susceptible. Only 18% were immune due to natural infection. 12% were immune due to prior hepatitis B vaccination. A total of 61 at screening, or 1.4%, had evidence of hepatitis B infection, of which 0.5% were thought to be acute based on the IgM test, and only about 1% were chronically infected, or 39 were eligible. So of the 39 eligible for enrollment, 13 were actually enrolled, 6 were randomized to the active arm, and 7 to the placebo arm. Importantly, there was 246 screened who had ambiguous hepatitis B status because of this isolated core detection. All of them were subsequently found to be hepatitis B DNA negative. So this is the experience of the 6 individuals with chronic hepatitis infection who were enrolled in the active arm. And you can see that in this person, there was gaps in PrEP medication use, as indicated on the left panel, where red dots indicate the presence of PrEP medications, and the orange dot indicates the absence of PrEP medications over follow-up. And you can see that there was viral rebound associated with gaps in PrEP use, but there was no flare in transaminitis, or there was no transaminitis hepatitis as indicated in the panels on the right. This is a person with a relatively low hepatitis B viral load associated with negative E antigen. The second case was similar, with gaps in PrEP medication coverage, indicating sporadic adherence to PrEP, but no transaminitis, no flares in the setting of an E antigen negative serology. The third case, similarly, had gaps in PrEP medication use and no flare, no E antigen. A fourth case out of 6 also had sporadic use of PrEP and no flares. So we actually did have some people in iPrEx who used PrEP consistently over the period of follow-up. This is one of them. He enjoyed a suppression of his viral load, which was eventually, the medications were stopped at the end of the study. The viral load rebounded, but there was no flare. This is the only one of the 6 who was E antigen positive and had a very high viral load for hepatitis B. Was consistently on PrEP during follow-up, suppressed the hepatitis B viral load, which rebounded after the end of the study, and again, there was no clinical flare of hepatitis. There were 2 individuals, the study protocol intended to exclude people with acute hepatitis B infection at baseline based on the IgM test. However, there were 2 acute HBV infections that were enrolled in the active arm of iPrEx. The first one was enrolled because his serologies at baseline were negative. He was in the acute infection window period with detectable DNA measured on subsequent testing when his hepatitis was diagnosed at week 4 of PrEP. This person went on to stay on PrEP because his LFTs resolved promptly and his serology resolved to immunity. The other case of acute infection enrolled was a 35-year-old who was enrolled with surface antigen detected, but his hepatitis B core IgM test was negative, as it turned out falsely negative, and so he was enrolled based on that eligibility. He had a transaminases up to grade 4 at 8 days of Truvada PrEP, at which point his surface antigen continued to be positive as an anti-core IgM became positive. He stopped PrEP because of the grade 4 elevation in AST and ALT. The transaminases resolved. 12 weeks into the study, he restarted PrEP and continued to have normal transaminases, and his DNA, which had been quite high at baseline, resolved to undetectable, associated with the appearance of E antibodies. As I said, 2/3 of those screened for the study and enrolled were still susceptible to hepatitis B. Every one of them was offered hepatitis B vaccination. 97% accepted at least 1 dose. 85% completed the series of 3 doses, and after 3 doses there was 87% seroconversion to immunity. After 1 dose it was only 44%. So hepatitis B was acceptable when offered. So in conclusion, hepatitis B vaccinations were low in this cohort of MSM despite global WHO recommendations for vaccination, and vaccination uptake was high when offered free of charge. With isolated anti-core antibodies, this was a relatively common serological pattern which was always associated with undetectable hepatitis B DNA, and there was no hepatitis flare. So we think that this isolated core serologic pattern represents natural immunity to hepatitis B and low surface antibodies. With the 6 people who were surface antigen positive at baseline, there was virologic rebound associated with sporadic use of PrEP, but no clinical relapses during or after PrEP use, and there was no TDF or FDC drug resistance. Acute hepatitis B infection resolved to immunity in 2 who started active drug. So we think the implications of this is that PrEP offers an important opportunity to offer hepatitis B vaccination to MSM and transgender women, and that surface antigen positive persons, that is chronically infected persons with normal or near normal AST and ALT, have a very low risk of hepatitis B flare when stopping hepatitis B active medications, and this is consistent with our experience from treatment. And surface antigen screening, we think, surface antigen screening delays PrEP initiation for many people and provides unclear safety benefits. So this work was made possible by the participants and their communities who believe that research could improve their lives. Thank you very much.